Hello, my name is Carmen Vleggeert and I'm working as a neurosurgeon in Leiden, the Netherlands, and I want to thank you for the invitation to give me the opportunity to tell you something about the research that we perform in our department and the research that we would like to perform in the near future. These are my disclosures, and this is the research group that we work with in Leiden. The main topic of our research is to observe the things that we do, the surgical interventions that we perform and the non-surgical interventions that we perform. And by doing research, we try to improve the things we do. This is what it all started with. It is the Sciatica Trial. Some of you might have heard from it. It was published in 2007 in the New England Journal. We're very proud of that. And this topic was to compare conservative versus surgical treatment of patients with a lumbar spinal disc hernia. And what you can see that in the end, whether you operated them or whether you stayed conservative, the outcome was the same. A more recent research topic is the Nectar Trial. In that trial, we evaluated patients that have a cervical herniated disc, and we wanted to know what is the best way to operate them. In that time, the prosthesis became very popular, and we started to do this research in order to evaluate whether this prosthesis, which is very expensive, is really better than the conventional method with a cage. To that end, we set up this RCT. We had 3 arms, putting in nothing in between, which is controversial, and putting in the cage, as we usually do, and putting in the new prosthesis. Well, what we looked at, our main research outcome was the NDI, the disability index. This is what we were able to include, over 30 patients in each group. And the outcome was that patients in all 3 groups had the same functional outcome. Likewise, pain in the arm and pain in the neck was also the same in the 3 groups. Now, this result is not only nice to share with the patient in order to inform the patient very well and in order to make a choice what type of surgery is good for the patient. But what is even more interesting is to look at all our outcome details and to see what we can learn from it beyond our primary outcome question. So we not only observe, improve, and gain awards for the research that we do, but we stay curious and wondering. And one of the things that makes us curious is this outcome. This is the global perceived recovery. And of course, in our articles, we say that patients were satisfied. However, if you look closely, then you can see this percentage of almost 70%. So that means 70% of patients is satisfied, which leaves 30% of patients that is dissatisfied. And that makes us wonder, what are the properties of those type of patients that are doing less well than the others? We did a subgroup analysis, combined our results with a trial from Nijmegen that had the same setup, and we increased our patient numbers to almost 170. We did a subgroup analysis, and none of the parameters that we evaluated made a difference. There was one parameter that interested us specifically, and that was namely the anxiety and depression scale. If you would have asked me in advance, what do you think that is a main determinant of outcome, I would have said, those patients that are a little bit nagging and very negative, that they do worse. And that appeared to be true. When we asked the patients to fill an anxiety and depression score, you could see that their NDI, so their functional outcome, was worse at baseline, and they also ended up worse. So what we were finally able to do is to make a prediction model. So we really like that. So what we can do is, before surgery at baseline, we can ask the patient to fill in their NDI, so their functional outcome at baseline, and also fill in the anxiety and depression scale. And then we fill it in here, and then we can show this to the patient. Look, this is the regular population, and you scored higher, so worse, on the anxiety and depression scale. Of course, you have to be a little bit nice to those patients to make them not too afraid to be operated. But you can inform them that in the end, that their outcome will be somewhat worse than in the general patient with an anterior discectomy. might be worthwhile. Something else that interests us, that is the Degeneration Scale. As you can see here, these are 3 types of patients that can enter your clinic with a cervical radiculopathy. And it is clear that this has less degeneration than this one. However, it is challenging to get it quantified. What we did is we took a parameter that we evaluated in another type of research, where we looked at the correlation between the range of motion and adjacent segment disease. And from that type of research, we took this parameter that Goffin developed that we can use as a degeneration parameter. And these numbers are too small, but I can tell you, if we, in our RCT group, 109 patients, correlated the NDI functional outcome to the score of degeneration, there was no correlation. Well, on the one hand, that can disappoint you. On the other hand, that can also give you an opportunity. Because this is not the final answer. Is what we need is larger numbers. Moreover, we need not only an RCT, because in an RCT patient population, patients are too much alike. We need more diversity. And finally, what we want to gain is prediction models on which patients will develop accelerated degeneration and which will not. Larger numbers, that's not a problem for us. We have, in our Leiden the Hague group, we work with a lot of hospitals. So if we have the information of all these hospitals, we have large numbers of data. Moreover, it will be a multi-institutional approach. Larger numbers means more scoring. In the 109 patients from our RCT, even combined with the ones from Nijmegen gaining 170 patients, I scored all those patients myself, and I had my PhD students score them, and sometimes even a radiologist. However, for 3,000 of those X-rays and even more MRIs, we will not score that by hand. And that is why we need machine learning, because we need automatic grading. Moreover, we need more diversity. So if we score all those patients, we will have a diversity of patients. And finally, we want to work on more advanced methods to find out whether a patient has accelerated degeneration. Maybe scoring an X-ray as we do is not the best thing. Let the computer find out what is the best way to score. So in order to anticipate on the outcome, we need prediction models. So that's the next step. We want to predict which patient will develop accelerated degeneration, and that can learn us what patient will do better or worse with the surgical intervention that we plan. Well, to tell you something more about that, I will ask Caroline Goedmakers, my co-worker, to tell you something more about that.
On the use of machine learning in research on the cervical spine and degeneration in the spine, we collaborated with CNOC. And we focused our research on patients undergoing anterior cervical discectomy and fusion, ACDF, and we wondered whether we would be able to predict, based upon these patients, their preoperative cervical MRI, whether they would develop new symptoms at the adjacent levels after their initial ACDF surgery. Well, about 15% of patients undergoing ACDF actually develops ASD, so this is a relevant question. But currently we don't have an accurate way to predict whether these patients will develop ASD, apart from a clinical expert's opinion. And that's why we chose to use the clinical expert opinion as a comparison to the performance of our model. To create our model, we included patients from both the Brigham and Massachusetts General Hospital, and we were able to include 350 patients. Then we developed a 2.5D convolutional neural network based on a ResNet50 model, and we were able to achieve an accuracy, or our model was able to achieve an accuracy of 94%, which is fairly high as compared to the accuracy of the clinical expert, which is around 63%. Also, sensitivity of our model was high, 75%, as compared to a clinical expert around 44%. And this is an interesting finding because eventually we would like to incorporate models like these into our clinical into our clinical workflow to be able to provide more personalized treatment strategies to our patients and therefore improve clinical care.
So these are our future plans. We want to achieve that we have data from all patients that we treat in our clinics with neck and or back problems. We gather them in a registry. Patients themselves fill in the prompts. The MRIs and X-rays are automatically scored for degeneration. And finally, we can also look into the inflammatory parameters that we will derive from the disc tissue that's taken out during surgery and from blood. And by that, we can hopefully develop a prediction model that can determine the success of treatment. And we can use that for informing the patient, but also for optimizing our clinical work. Thank you for your attention.